First, I'll introduce Dr. Paul Hart, who attended the Memorial University of Newfoundland, first ever graduating class, and led a career of his over 40 years as a physician, the majority of which Dr. Hart has served as a family care physician in Florida and across the East Coast. His research has ranged from studying high blood pressure in Canadian school-aged kids to assessing the impact of social stresses on family practice, of which there are plenty of those, to be sure. His medical career led him to practice around the world, including Latin America and East Africa. In partnership with the Addis Clinic, Dr. Hart's consulted on hundreds of telemedicine cases in East Africa and leads medical webinars for providers in Kenya and Somalia. A celebrated physician and humanitarian, Dr. Hart's the recipient of more than 15 academic, civic, and community awards. He lives between his residences currently in Florida and Vancouver, Canada. Carolyn Wanjau is a Kenyan clinical officer with Addis with nearly a decade of experience providing care to communities across Kenya. As the director of Addis Clinic's mobile clinics in coastal Kenya, Caroline specializes in providing medical support and community health education to vulnerable women and children. She is a Kenyan registered clinical officer and is currently pursuing her BSc in community health practice. Caroline has 8 years of experience in clinical practice. As the director of Addis Clinic's mobile clinics in coastal Kenya, Caroline specializes in providing medical support and community health education to vulnerable women and children. Caroline's area of interest are sexual and reproductive health, mental health, and gender issues. Caroline's Get Safety program in Kwale County provides safe spaces for girls and young mothers to talk about sexual and reproductive health and rights, provide psychological and psychosocial support for survivors of GBV, and offer free medical services to other underserved communities. With that, again, welcome both of our guests this morning, and Dr. Hart or Caroline, the floor is yours.
Thank you very much, and thank you everybody for coming. We're talking today about asynchronous telemedicine and how this can help you build your capacity to see patients. Next slide, please. So I think this is very basic, but what we want to do today is just have a brief definition of telemedicine. How effective is it? And there have been studies which we'll talk about. What we in the Addis Clinic do, and we'll have examples, or one case example, and then we'll open up to questions and answers. So telemedicine is, and this is a definition from an Oxford reference, is the use of the telephone or the internet to aid in the diagnosis and treatment, where the physician can seek a second opinion from experts at a distant hospital, or I would add a private office. Next, please. And there are different types of telemedicine. You can have the real time where you have a provider and a patient or another provider in direct communication. But what we're going to focus today is what's called store and forward, or asynchronous telemedicine. So asynchronous telemedicine is a situation in which a patient, or it could be a physician, gets the information that they would ordinarily present in person. And this can include not only the history, but pictures of x-rays, pathology reports, lab reports. And then they take this information and they send it, usually via the internet, to another physician or expert, and they ask that provider their assistance. And it could be assistance in helping to make sure that the initial physician has the correct diagnosis, or in guidance of treatment, or both. Next, please. So unlike where you are directly communicating, in this case, you have the information sent to the provider who is going to provide the help. And that information is then just provided to the new physician, who sits, looks at it, analyzes, use whatever other resources they're going to do. So what it does is it gives you sort of a unique position to provide this information and address many problems where you do not have the ability to do a face-to-face live encounter. Next, please. They collect, or this information is collected and stored, usually in the cloud, and it could be viewed later. It could be almost instantly that the provider to whom it is sent opens up the file and reviews it, or it could be some time later. In my own situation, I receive an email that there is a case for me to look at. Since I'm dealing with Kenya and I'm in Florida, there's obviously a time lag. So if that email comes in the middle of the evening, in the morning when I look at my emails, I go open it up and can address the case. And the information, as I said before, includes all the traditional information, the result of the provider in Kenya's interaction with the patient. What is the history? What are their concerns? Are they allergic to anything? What tests have been done? And I often will get a copy of labs, X-ray. I can see the X-ray image. It is sent across an EKG tracing, anything that the provider in Kenya feels will assist me. And then there's sometimes very specific questions. How would you treat this patient? Have I achieved, or am I looking at the correct diagnosis? Is there anything else I should do? Next slide, please. And of course, there's always a provider, in this case, on both ends. So the one provider takes the information that's shared by the patient, puts it into a format that is acceptable and is predetermined, and sends it off. I was told by and we'll get into this a little bit more, by the providers in Kenya, that it takes them 20 to 30 minutes to put a case together after they've had the interview, had a chance to think about the case, and then got the information. What happens, though, of course, is now you're separated, you've decoupled. So they are at different times. This is very good for evidence-based care, because I am then able to look at the case, look at the information, and go and get whatever reference sources I choose to help me informing my response to the provider. And I can also quote those sources and send extra information to the provider, not only about that case, but perhaps general information about managing a particular problem, be it stroke, be it sepsis, be it hypertension. Next slide, please. So there are pros and cons. The pros, as I said before, I can gather extra information. I can even consult with another specialist. And I have in the past sent an image to a dermatologist to confirm or to help me form an opinion. I can reach out to a surgeon or a medical specialist. And one of the difficulties, of course, is realizing that we're dealing with American-based systems where I am, but the system in Kenya is not as robust as what we have. And so get assistance in how I can taper the response to make it more meaningful. When I'm working on the case, there are minimum or no interruptions. I can sit at my desk and, or if I can't do it immediately, set aside a time as quickly as I can and not be interrupted. I can store the information and go back to it. I don't have to ask the provider, oh, what was the hemoglobin? Could I relook at that x-ray, please? It's there, I can pull it up. And what I can then do is I can take a photo here, make a video if I wanted to, and send that on. The negative, there is a delay. And sometimes that's critical, because if you are dealing with a problem such as hypertension, which is not well controlled, that delay is not critical. But if you're dealing with a septic patient who seems to be deteriorating, that delay can be critical. Also, you lose entirely, unfortunately, the personal contact. Even though you're at one end of a computer and somebody else is on a computer screen, you still have the ability, of course, when you are doing real time, to see their facial expressions, to hear how their voice is describing it, to clarify something if you don't think you fully comprehend what they're saying, or you want more detail. And as this final point says, you just can't get the facial or vocal cues. Next, please. There are other considerations. Privacy. We're now using telemedicine in a way that with constant worry now about computers being hacked, information, how it is stored, people getting into it. We have a different doctor-patient relationship. And what is that relationship? What is my relationship to the patient that the provider in Kenya has seen? What is the standard of care? Is it the standard in Kenya? Is it the standard in the US or whatever other countries? The Addis Project also deals with Somalia, but I'm sure the Global Telemedicine Network deals with many more countries. Whose standards of care do we use? Whose guidelines do we use if we are treating a situation where there are different guidelines? And then it's very difficult to critically look at the interaction. There's nobody, if you can't really record, if you could record a live session, you're able to get much more information, a much better understanding of the skills, how the providers are performing. I get a question, I go and I look at it, gather what sources and send it back. It's hard. It's hard to do research. I've done 500 cases, I just looked up the other day, since I joined Addis Clinic. Not all cases have all the information that ideally I would want to research the information, because what the provider in Kenya is providing is not for research purposes, but to try and help me with the case. There's also, because of the delay, the situation where if I'm missing some information that I need, that I think is critical, there's an additional delay. There's a 7-hour time delay between Florida and Kenya, or 6 hours. So if I question the provider, please, can you elaborate or give me more information on the neurological exam, or can you get a repeat CBC? And that's the middle of the night in Kenya, there are extra delays. Next, please. So let me pass this over to my colleague to tell the story about the Addis Clinic.
Thank you, Dr. Paul. We're going to talk a little bit about the Addis Clinic and our missions and visions, and also discuss one of the cases that we've been able to handle with Dr. Paul. Our story is a decade of experience in the digital health arena. Our main core business is telemedicine because we are bridging the gap between healthcare providers and patients in our country. In Kenya, there are only 0.18 physicians per 1,000 people. 74% of Kenyans live in rural communities, and most available doctors are in urban centers. So hence you find the need for more services to be taken to the rural areas. And some of our projects also include that, working in underserved communities and providing healthcare to underserved communities. And through telemedicine, we are able to have consultants help us to handle some of these cases, cut the costs for our patients, and also improve outcome. In Somalia, there are only 0.01 physicians per 1,000 people. As you can see, those numbers are not really good for people. So working through telemedicine, we're able to bridge this gap, which is an amazing thing. Next. Our mission and vision. Our vision is, well, just to say it plainly, is we want to see a future where we have global health equity, where we can reach the patient in the last mile. So how do we do this? We empower frontline health workers and their patients in low resource communities by bringing primary and specialty medical expertise to their clinics. And we do this through telemedicine because our clinicians on the ground are connected to consultants through our telemedicine platform. So if you're in need of a cardiologist, you're in need of a pediatrician in the most rural part of Kenya, you're able to send your case and you're able to sort out this patient without the patient incurring any cost to go and see the consultant who might be far away in an urban area. It also leverages asynchronous telemedicine technology where you're able to collect information, store it, send it, and then you can do proper follow-up for our patients. Next. How do we do it? We do it in different ways by a philosophy of primary care that is accessible, coordinated, team-based, patient-centered, encourages providers and care teams to meet patients where they are, simple to complex conditions. So what we do, like currently we have mobile clinics. That means clinicians like I on the ground will go to our patients wherever they are. We're able to handle their cases from the comfort of their environment so that they don't have to, because you also know one of the other issues is the travel from home to hospital is also an issue. We've seen cases where a patient is suffering at home, is not able to get to the nearest facility because they do not have enough fare. So if we are able to access these patients and we're able to give them full all-round care, even though I do not have the medical expertise, but I have a consultant on the platform who's able to handle our case, then we improve patient outcome. It also empowers clinicians because then you're given knowledge and understand some of these cases. So the next time you encounter such a case, you literally do not have to go back and consult, you can handle them. Next. So how do we do it? It is very easy. The telemedicine platform, Collegium Telemedicus, is available on URL. It is on App Store. It's on, you literally can just download it on your phone, and then an account is created for you, and then you're able to create cases, and they're able to be allocated through our triage officer. On average, we've done 1,750 asynchronous teleconsultation per year since 2017. Coordinated and team-based. What we like about our platform is that we have volunteer medical corps. We have a network of over 100 physician volunteers spanning 26 medical specialties across North America, Europe, Africa, Asia, and Australia. This means I do not believe there's a case we can send and not have someone able to sort it out. As Dr. Paul said, even if I send a case and he needs to consult through the asynchronous process, he can always consult and then get back to me wholly with a reference from the other consultants that he's been able to reach on. We also have on-ground recruiters and trainers. So us on the ground, we are able to recruit our fellow clinicians in different hospitals, in different clinical settings, train them in using our application so that we also, again, improve medical outcome to all, most, if not all our patients in our countries. Personalized triage and case management services. We have a triage officer who gauges the cases, looks them through, and allocates them to the appropriate consultant for proper case handling. As I said before, continuing education and training opportunities. This means through the platform, you are able to learn. Because what we see, most of our consultants just don't respond directly to the query. They literally give you information, they give you materials so that you're able to learn from that particular case. So that if you encounter the same type of case, you're able to handle it without having to go back and consult about it. Next. Patients treated in their community by their trusted healthcare providers. This is basically what we've discussed before. So currently we're running mobile clinics in Kenya, in Somalia. That means you have a trusted medical officer or clinician on the ground. Clinician on the ground. So the community is able to present their cases. Sometimes we have issues in terms of sending one patient to a different consultant. They might not go because they're not comfortable. But if you have one clinician who's able to handle these cases through consultations, then it is easy. You're able to provide quality care to our communities. Utilized within approximately 175 public and private health facilities. This is the beauty of it. As we discussed previously, we train clinicians through facilities in our countries to be able to use this platform, to be able to benefit and also improve patient outcomes in their facilities. Because we know the lack of consultants is not only even in urban areas, you can find one consultant who's handling over 5 referral or 2-3 referral facilities, which can be a bit hectic. But if you have a telemedicine platform where you're able to send those cases, then it reduces turnaround time for the patients, and it also improves outcome. Supported over 250 frontline health workers with direct access to first and second opinion in diagnosis and treatment plans. This is what we've discussed. The frontline workers are given information. Our frontline workers are equipped to handle cases that they might not have been able to handle before because of the lack of the specialty. So right now they're equipped with this, so they can even get a second and third opinion and be able to make a proper decision when it comes to the treatment plan. Continuity of safe, accessible care. It's a way of bridging the gap. So we're doing our bit as the Addis Clinic to bridge this gap. We're doing our bit to improve patient outcome by providing such a service. Next. So here is just a list of some of the complex conditions that we handle. You can see it spans all through neurology, pediatric rheumatology, pediatric urology, radiology, all this. You're able to log it into the platform because they have different templates. So depending on the kind of case you're sending, you can always choose a different template, be it pediatric, be it adult, be it general, or be it radiology. You're able to pick a different template for the kind of case you're sending so that when the response is coming back, it is specific to the kind of queries that you have.
If you want to look now of how effective are we?
Mm-hmm.
And it's interesting that the National Academy of Science talks about the fact that telemedicine can increase the quality of healthcare, reduce costs, avoid unnecessary emergency visits for rural communities. And when I get a referral, often there is no other source of care except for the provider in Kenya who is with that patient. That patient would not be able to get care by traveling to another place, either for geographic, financial reasons. And the telemedicine allows not only hospitals, but these providers to give care. Next slide. Kenya actually has done studies which show that they can get the same quality of care and advice if a patient has a telemedicine or asynchronous telemedicine experience as if they travel to see a nurse. And this means that we are able to be extremely effective. They've shown that they can manage cardiovascular disease very effectively by this form of telemedicine. Next slide, please. And here's a study which looked at the effectiveness in Nairobi. We're talking about home exercise programs, monitoring, and you had achieved a significant reduction in hospital costs as well as travel costs. And here we're dealing with a country which is not, which is poor relative to the US and other countries, but telemedicine has definitely helped the healthcare and the accessibility in Kenya. Next slide, please. So what we'd like to do now is talk about an actual case. And this is an actual case that the two of us worked on. So if you'd like to start off, talk about the patient that you saw.
So this is a 70-year-old woman I saw in a very rural part of Kwale, where I'm currently based. Let me give you just a background of the issues that she faces. She lives in a rural area. She's a diabetic who's on insulin, and there is no electricity in that homestead. So we had been struggling with controlling her sugars, and we always factored in the fact that maybe the storage was an issue or the dosing was an issue, because she's also an illiterate woman. She's a 70-year-old woman with a past medical history of 10 years diabetes, who is being evaluated for blood glucose medication. She had been previously prescribed with insulin 40 international units twice a day, metmorphin 500 milligrams BD, and Nogluc 500 milligrams at night. Please note, unfortunately, the only drug that she's able to get is the insulin and metformin, but she's not very compliant with the metformin. Within the last few weeks, she collapsed due to low blood sugar and was taken to a facility where her diabetes regimen was changed to insulin 30 international units in the morning and 20 international units at night. She refused glucophage at this facility. Her recent blood sugars have run anywhere between 25 millimoles to 2 millimoles. She says she has blurry vision with blood glucose abnormalities. Her HbA1c measured, that was when this case was being referred in July, at 8.7. For the past 3 days, her blood glucose level had been 4.3, 5.3, and 4.8 millimole. She lives in a rural area with variability in electricity, so insulin storage and administration has been problematic. My main aim was to quickly improve compliance for this patient fast, because we would like to change her to per oral medication, which would not be a hindrance in terms of storage. So that will mean we need to tap her off the insulin. That's when I sent this case to Dr. Paul for guidance. Next, please.
The former slide, if I could just have you move back for 1 second, please. I'm sorry. The former slide does bring up a number of problems with international medicine. The names of drugs are different in different countries. And it means that the provider, wherever who is getting the consult, is faced with checking, looking up, finding what medications are being used and what is equivalent to in the country where they are. The forms of 25 moles and millimoles for glucose are different in Kenya than we use in the US. So we have to convert units. So this is a problem that is, I think, universal when you're dealing for country with country. The same medication is called under different names. Now, if we can move on, please, thank you. I happen to be near my computer. Within 30 minutes, they had sent it. Within an hour, I had looked at it. I'd made some recommendations, and what I tried to do is, in every case, make sure that I explain why and what the basis is of my recommendations. Sometimes it's easy. I must note that compared to the practice that I had in Massachusetts in the United States, the cases that the providers in Kenya seen are often much more difficult. The level of illness is much, they're more severe. They present later on into a condition. So they're dealing with a lot of difficult issues, But what my recommendation was to slowly switch this patient from the insulin as they put on the oral agents and to monitor that patient closely. I did reach out to find out the results, and I was told that the patient was responding.
The patient is currently doing very well at 15 international units in the morning and 15 in the evening. Her sugars are random. Last we checked, that was yesterday, was 7.5. They've been stable for the past couple of weeks. So yeah, our only issue right now is the compliance, but so far so good. So this is one of our successful cases on the platform.
So our challenges were volunteer based. And to find sometimes a volunteer, I know can be difficult depending on what the case is. Some of our volunteers do not feel, and I have in the same situation, that they are competent to give a good opinion, and the case is then moved on to a different volunteer. We have problems, as I mentioned before, with the names of the drugs, the variation in different illnesses, conditions which I do not see in the US basically at all. Sometimes it's just problems, just transfer of information, just because of the internet. Problems in Kenya with connectivity. Kenya suffers from a problem, which we do in the States, but I think much more a difficult problem in patient follow-up. Patients are lost to follow-up or don't come back for a considerable period of time. And it is a resource-poor country. So it's very hard to implement treatments. And just to give you a current example, we're currently talking about migraine. If you look at sumatriptan, it costs about $1 US in Kenya. That is a major burden for a lot of their populations. So when we make recommendations, we have to be as aware as we can as to the cost and the burden that we're placing on the patient, or for the provider. If easy for me to say, please order a CAT scan, that may not be possible. It may not be possible to get more than basic lab work at the facility, and they would have to have the patient travel considerable distance. And also, of course, there's always a new way of dealing with healthcare for some of the providers in Kenya, and this is for them getting used to it, as well as the providers here in the United States and other countries learning how best to use the platform. Next, here's some, and this will be available, as I understand, with just publications talking about what we've talked about. Thank you so much for your invitation and for listening to us. And I guess we can entertain questions.
Great. Thank you so much, Dr. Hart and Ms. Wanjiao. I'm not sure the pronunciation, sorry for that, but very nicely presented, and such an important topic, particularly because of the challenges you mentioned in communications, time zone barriers. With that, I'll start with an initial question, picking up on that. For your volunteer medical corps, the 100 or so that you mentioned are available for consultations. I take it that would be after someone like yourself is presented with an asynchronous case. What sort of incentives are there in the recruitment of the volunteer medical corps? What essentially drives their interest to maintain their relationship as a volunteer medical corps member? I'm thinking that there may be incentives such as simply their humanitarian nature and their desire to participate, Perhaps maybe community service hours that for physicians in training might be a requirement for their training and to register those hours that they may be available and help in your efforts. What is it when you recruit for those volunteer medical corps clinicians that drives their membership in that corps and also keeps them on board to sustain the capabilities of what you're doing?
So I can go ahead and answer that. Good morning, everybody. I'm Megan Moretti. I'm one of the co-directors of the Addis Clinic and longtime physician recruiter to our volunteer medical corps. So I would say that the first item you mentioned, Dr. Pecchia, is the primary driving force amongst our volunteer medical corps. These are all physicians. We also have nurse practitioners, nutritionists, and speech pathologists and other medical professionals as part of that corps. And they are all interested in volunteering. They're all interested in being part of a humanitarian type mission. They're all also interested in maybe learning more and challenging themselves. Most of them are all in practice currently in their home country or their hometown and don't necessarily have the means or the opportunity and the time available to travel elsewhere to gain that experience. And so, by being part of our volunteer medical corps, they're also not just traveling somewhere for a couple of weeks, leaving and losing contact. I would say that many of our physicians, such as Dr. Hart, know a number of our refers by name. If you asked him, if he knows who Felix is, or he knows who Anthony is, or he knows who Caroline is, he would certainly be able to say, yes, he does, because he gets cases from them and communicates with them through the telemedicine platform now for, a couple of years on a regular basis. So I think they appreciate that long-term relationship that they're able to build and maintain with our volunteers, or our referrers or clinicians on the ground. I also think that they appreciate its flexibility. So it's something that, they can get an email that they have a case, and if they have a block where a patient canceled, or they have, some time at lunch or in the evening, they log on to the platform and they're able to answer that case then and there, or at least get started on their response. And so it's a very high impact opportunity, but in terms of demand on time in a profession where people are limited in time and, have a lot of other demands placed on them professionally, it's something where they can continue to volunteer while doing what they usually do on a daily basis. And that's why they stay.
If I could just add just a little bit, first of all, just the mechanics. Once the case is put together, one of the physicians or one of the volunteers in Kenya assigns it to somebody, and you'll get an email saying, can you respond within 24 hours to this case? If you can't, you let them know, they reassign it. Personally, because I'm basically retired, this is a wonderful way for me to keep in touch with my medicine. I've formed, I think, a lovely relationship with colleagues, even though it's only back and forth through the telemedicine, but I get to know them, they know me, they know the type of response that I'm going to give. So it's a personally very rewarding, feeling to say, yes, I know I've helped somebody. And I also try and expand my answers so it will be more education, because the physicians there are limited in continuing education opportunities. So if I can include more information about the guidelines for hypertension, diabetes, sepsis, whatever we're talking about, I know that they have been a resource to say, oh, what did he say is the first line therapy for that? And they can go back when they have another patient that's somewhat similar, as had already been mentioned.
Great, thank you for that answer. That's very helpful. Segue in front to, sorry about the logistical questions, but the devil's in the details, as we all know, when it comes to outreach and, collaborating in this way across borders and across different cultures and languages and time zones. One thing that we've noticed and run into at Global Offsite Care is a major firewall to delivering care, using the example that you presented as a case in point. How do you overcome medical liability issues that might vary from country to country, or even within country, from one zone of a country of, let's say, Uganda, as an example? How is that addressed so that the volunteer medical corps members can feel comfortable with not only with the liability issues that might be attached to opinions that they might generate out of the goodness of their heart, and also how to understand or receive training, if you will, in the variations, sometimes perhaps within the country itself, language, culture, and other barriers that might exist on the ground.
Excellent question. So in terms of liability, all of our telemedicine is provider to provider. And so the provider who is sending the case on the ground remains the provider of record. They're asking for an opinion of a colleague. And yet they know that they are the provider of record. And so that is something that we have received legal advice and opinions on, and, has passed muster. Many of our volunteers are also, employees at large major medical centers and universities, and, have to get sort of legal okay from their universities in order to volunteer for us. And that has continued to pass legal muster. So Caroline is in charge of making the decisions. And so, she does that in, the guidelines of her Kenyan clinical officer practice and licensure. And so if Dr. Hart were to do something that she wouldn't feel comfortable with, then the onus is on our refers to make those appropriate decisions. It would just be like asking a colleague, hey, what do you think about this medication for this patient? You, as the provider of record for that patient, have to make the appropriate decision based on your comfortability with their advice. So that's the legal question. In terms of how do we, navigate cultural differences as evidenced in our case study. First of all of our cases are in English. So that is, we don't currently navigate, language barriers. All of our Kenyan refers, do speak English and are able, communicate in English. Some of their patients, that might not be their primary language, but certainly all of their medical training was in English. So in terms of that, as the Addis Clinic, that's just where we are now. Would we love to be able to branch off and do more things not in English? That would be great down the road, but that's just not where we're at right now. Culturally, I think our refers, when we do our onboarding, both with our physicians and our refers, we give everybody training on the platform. We give them training on the knowledge that people are coming to this from two culturally, different perspectives for every case. And our refers are really good at saying, if Dr. Hart were to say, can you do a CT scan? Like, I don't know, and they'll say, no, we can't. And, then he'll try to give some information that then sort of circumvents that, diagnostic capability. So there's just a lot of good back and forth discussion. And I think that is because it's going to be different for every case. And everybody knows that that's important. We train our refers. You have to give these physicians on the other end the information that you would need. You need to paint the picture for them. And they really do a very good job of that. And so it's just, because every clinic is going to be different. Everyone's going to have different capabilities. There's 6 different levels of a level 1 facility to a level 6 that we might be dealing with in terms of where our referrals are coming from. So it's just consistent communication and training both our volunteers and refers to maintain that communication.
Oh, and also I must say that I find when I deal with literally every provider there, they're open to suggestions and ideas. So it's a, it's a really good dialogue. And as Megan says, I will reach out and say, I don't know if this medication is available in Kenya. If it is, and I do it generically, of course, here's a dosage you want to use. Here's another alternative that you may want to consider, because I don't have a formula, unfortunately, for what's available in Kenya for the numerous conditions you're presented with.
Yeah, and I've also found that our volunteer medical calls are usually very sensitive to our needs, because the cases we send and some of the questions they ask are very sensitive or very direct to our needs here. So that also makes it easy for us. We've had a case where they've asked, do they use a herbal medicine? And it was for sure, yes, the patient was on herbal medicine. So of course that changed the course of the kind of treatment management I was advised to use. So I also appreciate that our volunteers are also very sensitive to our cultural behaviors. And that kind of way makes it easy for us to collaborate.
Great, thank you. That's very helpful. To the audience, we have a few more minutes for your questions and concerns.
I have a question.
Sure, go right ahead. Dr. Otto, good to see you.
Yes, Pakel, good evening. I think it is evening there. I don't know, it must be morning in the US. Well, here it is 7 coming to 8. So it's evening. My question is to the presenters, Wanjo. So how are you able to sustain the project? Do you charge patients or it is purely donor dependent? And then secondly, yes, okay, the second question is basically on, do you operate only in Kenya, or I've seen somewhere Somalia? So is it both Kenya and Somalia, or it's only within Kenya? Then the third question is, okay, the third question is, so you said you have an app where people are able to download. Does your app only working within Kenya, or can we also in other parts of the world benefit, like here in Uganda? Can you also benefit from the app in case maybe someone would want to use the same app to offer the same services? Or it is only designed for you people? Thank you. Hope can get me well. Thank you.
Thank you, Dr. Otto. I might take those questions and I'll let Caroline jump in if she has anything else to add. So first, in terms of our financial sustainability, the Addis Clinic as a whole is purely funded by grants, private foundations, and individual philanthropic donors. So we do not charge clinicians or clinics currently to use our services. So as we've mentioned, we're provider to provider. So we are supporting providers in clinics. So say the clinic that Caroline works in, she is able, if they charge for that patient encounter, then that is up to the clinic. But we certainly are expecting they're not charging extra because they're now reaching out to the Addis Clinic to be able to give, give the type of care or, additional expertise to their patient. So we are supporting providers and clinics sign up to be able to access our services and our volunteer medical corps. And we do not currently charge them to do so. We do have some strategic plans to hopefully partner with county governments or other for-profit, maybe corporations that provide corporate health as a benefit within Kenya. And that would be to generate some level of revenue to sustain other programs in addition to our telemedicine program. But that would be for a different subset of people. But those that we're meeting at the last mile, we do not charge, and we currently don't charge anyone for any access to our care. I think the second question was I believe the telemedicine platform. So Collegium Telemedicus is not proprietary to us. It's developed by a company in the UK. It's been used by various organizations for telemedicine, practices and purposes. So we do lease the platform from them and use it. We have found that for now, it works well for us because it really, to most of us, it would look rudimentary, but it's really good for the remote, low resource, low bandwidth settings in which it's being used. And it's very easy to learn and to understand. So itself is able to be downloaded to anyone's phone, tablet, etc. To access the Addis Clinic services using that app. You do have to become a user under the Addis Clinic umbrella. Currently, we primarily operate in Kenya and Somalia. We have operated in the Addis came from our founders first started operating in Ethiopia. At the time, the interest and the sort of environment there just wasn't conducive to growth. And so we did start to focus in Kenya, where we've really been able to grow and blossom. We then moved into Somalia, which is a very different environment with a lot of challenges, but we do support 2 mobile clinics there that work in IDP camps around Mogadishu and Beledweyne. So in terms of partnerships in Uganda, we're certainly open and interested in expansion. So if anyone would like to reach out, I did put our information in the chat to discuss. But if you have an organization that's interested in using Collegium Telemedicus, they are a separate entity than us. And I apologize if there's something I did not answer. I know you asked 3 questions. Please let me know.
I just
Great.
want to take a brief moment and say, I know we're coming up on our timeline here. I did post also CME forms in the chat. So if you want to receive continuing medical education credit for viewing this amazing presentation, you are able to by clicking on the form in the chat. And also I'm going to stop the recording, which will be uploaded on YouTube later on, but I will keep the Zoom open in case anybody wants to continue the conversation now.
Great, and thank you, Alexa, for your support and hard work on this, and also to our guests today. This was quite eye-opening and part of all of what we do, which is to collaborate and learn from each other. And I know for one, I learned much today, and thank you for sharing your experience and observations and research.